Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Cancer Buzz is here at the ACCC 50th Annual Meeting and Cancer Center Business Summit. We're here all this week as oncology leaders from across the nation collaborate on the latest issues and trends in cancer care. One of those hot topic issues at AMCCBS is bringing comprehensive cancer care services into our cancer centers. We're here with Dr. Mandi Pratt-Chapman. She's the Associate Center Director for Community Outreach, Engagement, and Equity at the George Washington Cancer Center here in Washington, D.C. She's also an Associate Professor of Medicine. Hi, Dr. Pratt-Chapman.
Hi.
Thanks for joining us today.
Absolutely.
You're on a panel today on Thursday about comprehensive cancer care services. And I understand there's some new developments as it relates to patient navigation services. What are the new billable services?
Yeah, so just to clarify, I'm speaking today on LGBT issues for cancer, but I also have a very strong background in patient navigation, and that's covered also on the panel. And so I did write this summary as a leave behind here on patient navigation and the new codes for the new billable services. And really, the rule is pretty broad. I mean, it's trying to account for patient education, care coordination, in-system navigation, and even actually allows for navigation with very well integrated community-based organization navigation. So it's pretty broad to try to fill that gap in terms of the kinds of care coordination and patient support that we know that patients need. But this is definitely the start of a journey. So this was just January 1st. 2024 that these came out, so we're definitely going to be learning as we go in terms of billing. But the major codes for patient navigation include an initial 60-minute person-centered assessment and initial assessment and plan, and then 30-minute increments that are unlimited. So we'll see how it rolls out, but it's a huge win.
It is a huge win because we've been talking about this for a long time at ACCC, right? Who can provide these services now?
Yeah, that's a great question too. They also kept that really broad, so there isn't a named role. The physician payment rule refers to auxiliary staff, which can be really anyone working under the general supervision of a physician, or depending on your state, could be a PA or an NP, depending on scope of practice laws. But you would be billing incident to that general billing provider. So it can be anyone providing these services. So there's a couple of requirements. One is that you need to be trained. So the training component, if you have state-based requirements, you need to follow those. So the rule defers to the state. If you don't have state-based requirements, then you need to be trained in certain competencies that are listed in the rule, and you can get that training actually through the training that my team built about 8 years ago. You can access that at bit.ly/P training. And it's free, and it covers all of the competencies that you need to cover. There are other trainings available. You just need to make sure you're documenting that you have had training in those areas. And again, if your state has requirements, you have to follow those. If not, you just have to document that you've had training and are skilled in these particular areas. And then there are certain services that I mentioned, kind of doing that person-centered assessment, identifying patient-driven goals of care, care planning, care coordination, communication across providers, in-system navigation, health education, coaching, and then collecting the documentation and evaluation data that you need. So anyone who is trained and does those functions could, under the rule, bill under a qualified provider. So that's my understanding of the rule, and it's pretty broad. So I think that it's a win for the cancer community, but I will say that the only thing that I am very worried about is that CMS has a 20% cost share requirement as part of Medicare, and hopefully people who are in the greatest need will also have Medicaid, and that will cover their cost share. But my biggest concern about implementing these new codes is how it might unintentionally burden patients, or patients may not consent to services because of that cost share. So I think that's something we have to pay attention to. But hopefully, fingers crossed, that those in the greatest need will have secondary insurance to help with that.
So we'll have more information talking about the things you just mentioned in the show notes as part of the Institute for Comprehensive Cancer Care Services from ACCC. Dr. Pratt-Chapman, good luck on your panel today.
Thank you.
Thank you so much for joining us.
Absolutely.
We'll be here all week at the ACCC 50th Annual Meeting and Cancer Center Business Summit from Washington, D.C. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.